Here's the weekly reminder. Please log your attendance if you want to get CME credit. You're only hurting yourself if you don't. And then we'll go to just to introduce the whole thing. So most of you probably know, but the department sponsors typically 2 Scholar of the Year students every year. These are most often medical students between their first and second or third and fourth years of school, who can take the opportunity to spend a year with a faculty member in the neurosurgery department, doing a little more focused research time. And the goal is typically to do a more longitudinal project that you might not have time to do during your studies, but maybe also do some additional projects on the side. We have an embarrassment of riches of students this year. We have 5 students in the department doing scholarly years, and we're able to garner funding for all of them, which is a testament to the dedication of the mentors who helped find the extra funding as well. And I just want to start off by thanking, first of all, the students for their dedication to their work this year. And secondly, all of the mentors who have taken extra time to make sure that each of these students has had a fruitful and productive year in the department. So thank you to all of you. And today we have 4 of the presentations, and then our 5th, Giannino, will present in a couple of weeks when Dr. Germano is available to be here for it. So we'll start with Daniel Rivera. Daniel is an MS2 who completed his undergraduate degree at Yale before coming to Mount Sinai. He started working with Dr. Hadjipanayas very early, and then decided to continue his work with him after Dr. H left us for Pittsburgh last year. And so he, as a very dedicated student, traveled to Pittsburgh for this year to do his scholarly year, and is going to be presenting to us on some of the work that he completed in the last 12 months. So Daniel, I will give the screen to you.
Great. Thank you for the introduction, Dr. Morgenstern. Let me share my screen. Can everybody see this?
Yeah.
All right. So the title of my project is Magnetic Hyperthermia Therapy in Combination with Chemoradiation for the Treatment of Glioblastoma. So I'm sure that glioblastoma requires very little introduction with this audience, but just as a quick overview, GBM is one of the most aggressive forms of cancer in the human body. It is a grade 4 astrocytoma, and although it is rarely metastatic, it is notable for its rapid, diffuse, infiltrative growth into the surrounding healthy brain. And it is this invasiveness, as well as GBM's ability to develop resistant occurrence therapies, that makes it so difficult to treat, where even despite the current standard of care, which consists of maximal safe tumor resection followed by concurrent radiation and chemotherapy, the prognosis remains poor, and median survival for patients receiving therapy is only about 15 to 18 months. So novel therapies that are capable of synergizing with the current standard of care are desperately needed to increase patient survival and quality of life. So magnetic hyperthermia therapy is an extremely promising heat-based therapy that has been studied to treat various forms of cancer. Briefly, MHT involves the local delivery of magnetic nanoparticles to the tumor, and then subsequent activation of these nanoparticles with an external alternating magnetic field that causes them to oscillate and produce highly localized hyperthermia. So moderate hyperthermia in the range of 43 to 45 degrees Celsius is well known to induce cancer cell death through a variety of mechanisms, including the induction of apoptosis, increased production of reactive oxygen species, and even some of the shear forces from the physical oscillation of the nanoparticles. With respect to the treatment of GBM, hyperthermia has been shown to increase blood flow and oxygenation to the tumor, interfere with tumor DNA damage repair mechanisms, and open up the BBB, all of which can lead to more effective chemoradiation. But what really makes MHT stand out for the treatment of brain cancer is that unlike some other heat-based therapies, which often require the intraoperative placement of a thermal probe or some other procedure, MHT can be repeatedly and non-invasively performed post-operatively, since these nanoparticles remain around the delivery site for weeks to months. And on top of that, the AMF can penetrate through skin and bone to reach even deeply seated tumors, meaning you don't have to make any incisions. So all that being said, what we wanted to investigate was, does the addition of MHT enhance the anti-cancer effects of CRT, both in cell culture and then later in an orthotopic rodent model? And as part of this process, we wanted to develop a methodology for effective intracranial MHT, assess potential synergy between the two therapies on multiple cell lines. And if we were to observe any synergy, we wanted to take it one step further and begin to study some of the underlying mechanisms for why that might be happening. So here's a quick overview of our setup. We have an alternating magnetic field, or AMF, generator that's capable of performing MHT both in cell culture and in small animals. It allows us to test a variety of parameters when it comes to the AMF frequency and field strength. And we chose to use iron oxide-based nanoparticles for our experiments due to their well-established history of biocompatibility and efficient heating. And we delivered these nanoparticles through a needle directly into the tumor using a technique called convection-enhanced delivery, which allows us to bypass the BBB and minimize any potentially systemic toxicity. So we began in vitro. And prior to actually performing MHT in cell culture, we tested a variety of nanoparticle concentrations and AMF parameters to determine which settings would consistently achieve hyperthermia in cell culture, and that those results are highlighted in this table in the bottom right. And we found that a concentration of 0.7 mg per mil nanoparticles exposed to a 425 kilohertz alternating magnetic field consistently reached temperatures of about 44.5 degrees Celsius. So we then treated 4 different human GBM cell lines with either nanoparticles alone, 1 fraction of 2 grays of ionizing radiation, MHT alone, or MHT in combination with IR. And we performed an MTS assay 24 hours post-therapy completion to assess cell proliferation after treatment. And what we found was that in every cell line, the addition of MHT to IR decreased cell proliferation by a greater extent than IR alone. And these initial results were promising, so we wanted to explore whether or not that effect translates in vivo. So we first developed a model for repeatable intracranial MHT, where we delivered the nanoparticles via CED, and then placed cannulas, which you can see in this image here, into the skull, both in the hemisphere that received nanoparticles and into the contralateral hemisphere. And then we threaded these temperature probes through the cannulas to the depth that we delivered the nanoparticles. And we monitored temperature for 10 minutes during AMF application, and then for 5 minutes after turning the AM off. And what you see in the panels on the left are the results from multiple experiments in which we treated various concentrations and volumes, or concentrations just here, but we also tested various volumes of nanoparticles, where we monitored the heating. And what we saw was that first, intracranial heating is possible with our method, reaching an average temperature of about 45 degrees Celsius when using 8 microliters of the 80 milligrams per mil nanoparticles. And 2, iron mass of the nanoparticles determines the temperature of intracranial heating, which you can see by the fact that as you go down in concentration, the temperature significantly drops off. It's not shown here, but we also observed that the AMF field frequency and strength positively correlates with heating as well. And then additionally, in the bottom right panel here, we have shown the results from an experiment where we measured temperature both 24 hours and 48 hours following delivery of the MIONPs, the magnetic nanoparticles, and showed that we were able to heat to extremely consistent temperatures in multiple sessions following a single delivery of these nanoparticles. Additionally, we wanted to confirm that the nanoparticles were localized where we wanted them to be. So we performed CT scan on the left here, and then magnetic particle imaging on the right with our collaborators from Johns Hopkins. And you can see the nanoparticles remain highly localized to the injection site as shown by this hyperintense white region in the CT scans. And then although the image saturated here, because the concentration of iron was so high, the results from the magnetic particle imaging also confirm that. So now that we had developed an effective model for repeatable intracranial MHT, we wanted to test if the in vitro results would translate in vivo. So we performed a survival study using SD3, which is a highly invasive human GBM cell line that we implanted into the right striatum of athymic nude mice. And then we treated these mice with either CRT alone, chemoradiation alone, nanoparticles alone, MHT, or the combination of MHT and CRT. And for those mice receiving MHT, we performed 2 sessions, 20 minutes each. And for those receiving chemoradiation, we administered 2 subtherapeutic doses of temozolomide, 5 mg per kg, and 2 fractions of radiation, 5 grays each. So the timeline of our treatment scheme is shown in the bottom right. And after a predetermined endpoint of 60 days, we sacrificed the mice. And what we saw was extremely exciting. At the end of the 60-day period, none of the combination therapy group had died. And only about 50% of the CRT treated group remained alive, whereas all other groups hadn't survived, suggesting that the effect that we observed in vitro was translating in vivo, and that MHT may enhance the effects of CRT. So as I mentioned earlier, the next step was to study some of the reasons for why that was happening. So we looked at the tumor environment, microenvironment, and we stained for markers of inflammation, which is P-selectin, and then also DNA double-strand breaks, which is gamma H2AX, since DNA double-strand breaks are the primary mechanism through which radiation induces tumor cell death. We performed MHT in immunocompetent mice with or without CRT, also 2 sessions of MHT for 20 minutes and 2 subtherapeutic doses of TMZ and 2 5-gray fractions of radiation. And we looked at the levels of these markers both 24 hours and 7 days following treatment completion. And what we found was that in both instances, the addition of MHT to CRT increased the expression by a greater extent than CRT alone. And notably, whereas the elevation of P-selectin induced by CRT alone goes away after 7 days, it remains elevated after the addition of MHT. And these results suggest that MHT is inducing a tumor-focused inflammatory response and is leading to increased susceptibility and/or production of DNA double-strand breaks in these tumor cells. Although further investigation is needed to study exactly what the impact of MHT on DNA damage response machinery signaling pathways is, especially those involved in radiation and TMC resistance. Further investigation of the tumor microenvironment revealed that the addition of MHT to CRT may also limit tumor growth by potentiating a CD8 T cell and microglia-mediated anti-tumor immune response. IBA1 is a marker for microglia. And these results are promising since GBM is known to be an immune cold tumor that evades the host immune system. And that has been linked to its aggressiveness and resistance to therapies, in particular immunotherapy. However, the presence of immune cells within the tumor alone and without other markers is insufficient to conclude that they are singularly inhibiting tumor growth. So further investigation on what is happening here is definitely needed. So then we also observed that MHT, unsurprisingly, increased the tumor heat shock response, as shown by the increased levels of heat shock protein 90, both 24 hours and 7 days post-treatment. And as another potential tie into immunotherapy, HSP90 has been identified as a potential viable target for GBM immunotherapy. So overall, our study indicates that adjuvant MHT may induce tumor chemo and radiosensitization in cell culture, may induce some sort of anti-tumor immune response, and potentially confers a survival benefit to enhance the effectiveness of CRT for GBM. We developed a model for intracranial rodent MHT, and our study is the first attempt, to the best of our knowledge, to assess MHT and CRT combination therapy in an orthotopic GBM model. Future steps include more robust in vitro studies to assess MHT, not just with radiation, but also TMZ chemotherapy, and studies exploring the impact of MHT on blood-brain barrier disruption and permeability. And we also want to validate our survival results using a different recurrent, highly chemo-resistant cell line. So that's kind of what we're working like crazy to finish in these next 2 months before I go back. But I just want to give a really special thanks to Dr. Hadjipanayis and Dr. Boris. From the, it would take me another hour to fully thank you both for your incredible mentorship, friendship, support, encouragement over these past years. It's truly had such an amazing impact on my journey thus far. And I just want to thank you both sincerely for making me a better scientist, student, colleague, everything. So, and then of course, I want to thank the department for funding this incredible opportunity. This would not have been possible without your support, to put it simply. So thank you very much.
This was great, Daniel. Really nice work. I had one question to start it off, and it was, so we've had laser interstitial thermal therapy for a while for tumors as a way of heating up and targeting deep-seated and other tumors. How is this different? What does this do for us that lasers can't do?
Yeah, that's a good question. I think the main advantage, so heat is heat. I think, it's just about the delivery method for getting that heat to the tumor. Magnetic hyperthermia therapy is slightly lower in temperature achieved in the tumor. But the benefit is that because these nanoparticles stay at the tumor site for weeks to months, and because you can apply this AMF in a postoperative setting without having to make any incision, you can perform multiple sessions of heating over the course of those weeks to months, whereas with laser interstitial therapy, that isn't possible. So the potential to develop unique treatment schemes where you can combine hyperthermia with chemotherapy and radiation, I think is much greater with MHT than it would be for lead.
I think Alex had a question as well.
Sure. Hey, Alex.
Hey, Daniel. Great to see you, and great to see Dr. H and Dr. Boris.
Nice to see
Congratulations. I think you made it very clear how much work you've put into a very short amount of time. So congratulations on a fantastic year. It's been a privilege working with you.
Same to you.
Had incredible work, and this may be a question also for Dr. H, but as we know, Europe is a little bit ahead of us in this technology, and that they've done multiple human clinical trials to date using this technology. And obviously there hasn't been a big one here in the US yet. So this may be more of a theoretical question, but what do you think is the biggest gatekeeper right now for us to develop a fully fledged US clinical trial using this technology?
Yeah. Well, I can give my first thoughts and then, leave the floor to Dr. Hadjipanayis and Dr. Boris. But I think right now with MHT, I think the biggest limiting factor is some of the technology. I think the ability to, in real time, monitor temperature and location of nanoparticles within the patient is crucially important to effectively know what thermal dose you're giving, to prevent any potentially off-target heating. And although a lot of that technology is being worked on and is reliant on, some of the stuff that we talked about, like magnetic particle imaging, it still has a bit of a ways to go. I think the initial clinical trials that were performed abroad, both in Europe and other countries, have shown promise, especially with radiation. And I think more needs to be explored with the chemotherapy combination with magnetic hyperthermia therapy. But yeah, I think a lot of it has to do with just getting the technology there, because right now that's the part that's kind of lacking behind. But Dr. H, I don't know if you have any thoughts there, Dr. Boris.
Well, first of all, welcome everybody. Good to see the crew at Mount Sinai. Thanks for allowing us to be on today. So, Daniel, amazing presentation. Really proud of you and your work. And everybody, this is not just 1 year of work. This is multiple years of work. Trying to figure out models, trying to troubleshoot. I mean, these things are not easy. And hats off to Daniel who really just stuck with it and came up on top. And the other thing too is in the middle of this, we had to move and we had to get our lab up and running, and that's no small task either. So he was really integral to getting everything going. The technology that we're talking about today is very promising, and some of the earlier work that was done showed the initial efficacy, but the problem with those platforms that were used were rudimentary nanoparticles, and they had to use very high concentrations with associated toxicity. So we've been able to develop our nanoparticles with a separate company that's much more biocompatible, lower concentration, heating effect, and nanoparticles we think will be ready for prime time in the near future. So this stuff's all being carried out in a canine model at Johns Hopkins, and we're hoping to launch an exciting new collaboration here at a really big vet hospital in Pittsburgh, which sees one glioma patient a week, actually, which is incredible in dogs. Dogs develop gliomas like humans do. So a lot of work to be done still, a lot of understanding in terms of delivery, treatment planning, toxicities, combination therapies. But this is, we're hoping to get this to humans in the next couple of years, and this work that Daniel led was really instrumental to lay the foundation for this. Alex, you want to say a few words too?
Yes. First of all, hi everybody. Common faces, Alex. Special hi to Alex. He was in our lab before we moved to Mount Sinai. Thanks everybody for having us today. So I think Daniel, Dr. H mentioned everything. So the main thing is to a little bit also respond to Alex's question is nanoparticles is the key. So we have this collaboration with Johns Hopkins, so we're getting nanoparticles which are much more effective at a much lower iron dose. And the second thing is, as Daniel mentioned very correctly, the thermal planning. So you need to make sure that you hit, Dr. Morgenstein, only the tumor. You don't have like off-target like hitting. You want to hit maybe the margin more than the necrotic core. So all this treatment plan that we're working with Johns Hopkins, I think is key to move this to humans. So we know exactly what we're hitting, what we don't hit, off-target issues. And then the third thing is the imaging. So because of the high iron concentration, the MRI is completely obscure. So that's another thing that we're working with Johns Hopkins to develop the magnetic particle imaging, where we can, co-register this with either an MRI or a CT scan and locate the nanoparticles, where they should be, because we need to make sure again that it's delivered intratumorally.
Let's give Raja a chance to ask a quick question, and then we're going to move on for time.
Thank you.
Thank you, Peter. So actually, I can ask my question later because I know we're running late, but I just wanted to really compliment Daniel. This is an outstanding project that really is a sophisticated multi-year project that really represents, I think, one of the best projects we've seen. And it's in all the years I've been here. And it's a credit really, Daniel, to the work you've done, and obviously for Costas for his mentorship. It's the type of work too, and the type of depth that is a great role model for other students too, because as you all know, basic science research is challenging and really requires dedication, which is not often easy to do as a medical student. And it really takes a lot of mentorship and really close communication. So Costas, that's a huge compliment to you too. We certainly miss you. It's fantastic work. I'll ask my actual question later. Thanks.
Thanks, Dr. Srivastava. Definitely a team effort.
All right, thank you, everyone. So I think actually we're going to continue to change the order and go to Alex. I think Dr. Kellner's in the OR, and I'm hoping that he'll get out with the other two, but no worries if he doesn't. We'll have it recorded for him. I'm happy to introduce our second speaker for the morning. It's Alex Devarajan, who's a student also at Mount Sinai, doing his scholarly year before entering his final year of medical school to apply to residency in neurosurgery. He spent the last year mentored primarily by Dr. Fifi, doing research in the vascular space, largely on vein of Galen multiomics. So Alex, looking forward to hear what you have to present to us this morning.
All right, let me share my screen. Okay. Is everyone seeing a presenter mode or speaker mode?
Yeah, just swap your displays.
Yeah. There we go. Okay. So hi everyone. Thank you for the introduction, Dr. Morgenstern. My name is Alex. I'm a rising fourth year medical student here at Mount Sinai. And I've had the privilege of the Department of Neurosurgery for spending the last year working with Dr. Berenstein and Dr. Fifi, specifically looking at VMGM malformations. Today, I want to talk about kind of just some of the multiple areas we've been looking at in the process of updating the way we kind of diagnose and also manage these malformations as a whole. So no relevant disclosures. As a brief overview of what VMGM malformations are, they are congenital arteriovenous malformations between the choroidal circulation of the brain to what is known as the persistent median prosencephalic vein of Markowski. This is the embryonic precursor to the vein of Galen in the fetus. Neonates that present with the vein of Galen malformation can present with high output heart failure, hydrocephalus, failure to thrive, and even mortality, while infants who present with vein of Galen malformations can have hydrocephalus, seizures, and developmental delays. The primary method that we use to treat this is endovascular embolization through either a transarterial or a transvenous approach. In our particular practice, we prefer the use of liquid embolic agents like onyx or glue. And the mortality left untreated is about 76.7%. So it represents a fairly high mortal condition that we are looking to update the management for. Here at Mount Sinai specifically, we had about 4 decades of experience actually managing these malformations. The guidelines have evolved significantly since the 1980s as technology and technique has improved in all aspects. But while their own outcomes have improved significantly, we want to know if this actually did uphold nationally. How has the field changed with regards to outcomes for these patients? Embolization as a procedure only became increasingly popular within the 1990s itself. Previously, microsurgery was used, which has a near 100% mortality rate. So, to get an idea of what the field looked like nationally, we used the national inpatient sample, thanks to Trevor, one of the residents here, and identified all patients under the age of 1 who had an AVM over a 15-year period. So we can pretty comfortably say that outcomes have improved for vein of Galen malformations. This change in incidence that you see is due to change in the sampling design, but this trend overall of a decrease in mortality is quite clear. There has been a lot of development for new technology that has increased applicability in the management of these malformations. We've refined and honed our existing methods for managing. We also have an improved understanding of the pathology itself. So today specifically, I want to talk about the areas where I've been working this past year with Dr. Fifi to kind of make advances in understanding exactly how we look at these malformations. These 4 bolded categories specifically went to embolize, characterizing angiogenesis, looking at curative embolizations of these malformations, and also long-term outcomes is what I'm going to focus on, with these first 2, identifying risk factors and diagnosis, being more next steps I'll talk about at the end of the presentation. So what clinical factors should we be considering when deciding to embolize? Previously, the Bicetra score, identified by Dr. Laswanias back in 2006, is used as a decision-making algorithm to determine when to intervene in these malformations specifically. This is a picture here of the scoring that's utilized, with the idea that if a baby scores over 12 points, that they can be embolized in the infantile period. If they are scored between 8 to 12 points, they require an emergent embolization in the neonatal period. And if they are scored under 8 points, that they should not be embolized at all, and no treatment will be able to help them. This algorithm was developed, of course, at a time when the outcomes were a little bit worse than they are now. And so since these outcomes have improved, we want to see if this algorithm is actually still held true or if the cutoff has actually changed. So we reviewed 55 patients that were born here at Mount Sinai with appropriate fetal imaging to understand exactly how this may have changed. And what we can comfortably say is that the window for embolizing has increased. In the neonatal period, the cutoff that we now see for intervening is a higher cutoff overall. We have an average score of 13.2 versus the previous 12, and a larger variation in that score as well. So we're able to say that with advances in our technology and greater experience managing these malformations, we can afford to intervene sooner and also demonstrate excellent outcomes to match. The next point that I wanted to focus on is the idea of angiogenesis in vein of Galen malformations. Angiogenesis in these malformations is a little bit different than a typical arteriovenous malformation. Arteriovenous malformations tend to recruit from dural vessels as feeders during the process of their management, but vein of Galen malformations often develop this very extensive network of small caliber collateral vasculature. It sits in the extraaxial spaces, so within the third ventricle, the choroidal fissure, and is not really surrounded by any normal brain parenchyma, but it does significantly complicate the management of this condition. If we try to access the malformation from an arterial approach, this network gets in the way and prevents us from actually reaching the malformation with embolic material. These networks also progress over time and further complicate with age. We did a study specifically confirming that this subset of patients does demonstrate a higher symptomatic burden and also requires a greater number of embolizations to achieve total occlusion. The reason why this occurs is unknown, and the reason why some patients develop it to a greater degree than others is also unknown. What we wanted to know is if malformations that have this angiogenesis can be effectively treated. Typically, in the past, patients with these kinds of angiogenesis are very difficult to treat and have worse outcomes overall. And of course, the tortuosity of these vessels and collateral vessels makes endovascular management very difficult. But within the last 10 years, there have been a number of advances in technology, which have led to the development of these miniature dual lumen balloon catheters, which allow for simultaneous injection of embolic agents and also prevent reflux within the single catheter itself. Previous catheters like this were too large to be utilized, but we now have access to these miniature catheters that can be possibly used as a novel application for the management of patients with this particular complication in their condition. So we reviewed all these patients that had a diagnosis of vein-to-vein malformations and were embolized using a miniature dual lumen balloon catheter. And we were able to comfortably say that we were able to safely devascularize and obliterate this malformation in 7 patients that have presented with angiogenic vein-to-vein malformations. We noted there were networks, again, in extraaxial spaces. This is important because the extraaxial space means we were able to achieve complete devascularization without minimal concern for actually harming brain parenchyma, as there was few vessels in the way that were considered normal. We were able to achieve a high degree of technical success. In all of our uses, we were able to successfully embolize the malformation, and we achieved distal access within very small arterial feeders that were previously not able to be catheterized due to their size, a vessel diameter of 0.68 millimeters specifically. All of our patients had significant penetration, and 5 patients since then have been subsequently cured of their vein-to-vein malformations. We encountered a couple of complications with the use of this catheter, but no permanent complications overall. We had a tip entrapment, which we were able to retrieve, and 1 patient did experience an intraventricular hemorrhage, which ended up being resolved on its own with a minimal neurologic deficit afterward. So to give an example of a patient that I'm going to talk about who kind of represents, I think, the best representation of these advances we've made in management overall. Here specifically is the angiogram subtracted AP and lateral views of the right common carotid artery, which demonstrates the malformation with numerous fistulous feeders from penetrating branches of the bilateral pericallosal and posterior cerebral arteries, and with dural supply from branches of the bilateral middle meningeal and tentorial arteries. This specific patient developed angiogenesis after 1 embolization. Here we are. You can see on these views of the left vertebral artery a fine collateral network within the 3rd ventricle and choroidal fissure, which significantly complicates their transarterial access. So we were again able to use this miniature microcatheter to catheterize the feeding vessels and achieve penetration of it. Here you can see a subtracted AP and lateral view, which demonstrates the balloon actually within a distal left pericallosal feeder that was traditionally considered too small to access to this extent. The feeder supplies the malformation in a relatively safe location, as there is no evidence of normal vasculature or brain in this area. And here is the result post-embolization, demonstrating occlusion of a significant degree of the left and medial networks with a reduction in the shunting through the malformation itself. So the key point to note here is that the miniature dual lumen balloon microcatheter is able to maximize effectiveness of these transarterial approaches, which we know to be the standard for managing these vein-to-vein malformations. But patients with these networks do need extra caution to ensure that their arterial supply is minimized, because attempting to close the malformation can be very risky. It can lead to complications like hemorrhage and so on. But maximizing the effectiveness of a transarterial approach prior to opting for this closure allows us to minimize this risk of complications significantly. So when we actually do end up looking at closing these malformations, how should we go about doing that? Well, there are a few options. One is the traditional method of a staged transarterial embolization. About 80% of our cases here at Mount Sinai from 2010 to 2020 have been closed through this method. But we've recently seen advances in transvenous approaches that now also present an attractive option to achieve closure. About 20% of the cases from 2010 to 2020 were achieved through a transvenous approach. Specifically, the use of what's known as the pressure cooker technique is able to offer a high rate of angiographic closure. In this technique, we utilize a transjugular access instead of a transfemoral access, and utilizing 2 or 3 microcatheters, we're able to navigate them into the vein and trap them in place with a plug made of coils and glue, and then inject onyx for obliteration of the malformation itself. And so we know that this technique has a high degree of occlusion, but how does this technique compare against traditional transvenous methods? And how did the patients fare clinically? If we see they're angiographically closed, does this mean that they're going to clinically do well in the long term? So we reviewed the cases from 2 different centers here at Mount Sinai and in collaboration with Alfred Krupp Hospital in Essen, Germany, to identify all patients who were cured through the pressure cooker technique. And here specifically, 25.7% of the patients that we've cured in the last 3 years were from Mount Sinai Hospital treated with the pressure cooker technique. We identified 15 patients overall that were closed in this method. Here is the same patient that I showed before, but now after 5 transarterial embolizations, which shows a very markedly reduced degree of shunting through the malformation. The supply is primarily from thalamoperforators and the right lateral choroidal arteries. So considering that the residual feeders were primarily composed of this small caliber vessels, the malformation is now pretty considered amenable to closure by a transvenous approach. This is just an X-ray demonstrating the microcatheters within the vein. Here you can see 2 microcatheters, or 3 microcatheters overall, 2 of which will be used for onyx injection, 1 of which is used for coils and plug formation. And then here is a post-embolization X-ray showing the cast of the pressure cooker. Obviously, a large amount of embolic material is placed during this procedure. And follow-up angiograms through the left vertebral artery after this transvenous embolization demonstrate a complete obliteration without any evidence of further shunting through the malformation itself. So when we actually look at the data, we can see that these patients do present very symptomatically with a high degree of symptom burden. And we were able to utilize stage transarterial embolization to reduce the degree of shunting. So they were amenable for obliteration by a transvenous embolization eventually with this very low symptomatic burden. Really, all that was left were these very small arterial feeders. When we compare the degree of occlusion, we see that it's significantly higher using this new method of pressure cooker versus the old method of transfemoral coiling. And 3 of our patients experienced a small post-procedural hemorrhage, but all patients recovered without deficit. We achieved 100% technical success, and the degree of occlusion was also 100% in these patients. On long-term follow-up, every patient who we've been able to achieve angiographic follow-up on has demonstrated persistent obliteration, and every patient that we've seen in clinic has either demonstrated complete resolution of their symptoms or what we consider to be an improvement with a dramatic progression in their developmental milestones, reduced therapy needs, and less academic support required. So we really see that there's no permanent morbidity or mortality that occurred with this approach. But why should we aim for full obliteration if the symptoms were low and manageable prior to opting for a transvenous approach? Does it make sense to go for it? So we really want to know, how do these patients fare in the long term? Mortality in venous malformations was only really significantly improved within the last 2 decades, as there's extremely limited data on the clinical outcomes, as the mortality, again, was very unacceptably high in the past. But we were noticing that adults were starting to return to us after subtotal occlusion with a very precipitous functional decline and focal neurologic deficits. They had a
couple more minutes, Alex. Just keep an eye on it.
Yep, thank you. They presented with significant angiogenesis and high flow shunting. So we really wanted to know if these patients who had complete closure in childhood fared better than those who were only closed in adulthood. So we identified all patients over the age of 18 from 1982 to 2005 and reviewed them, and then grouped them based on their time of cure. This is the overall cohort. As you can see, they are much older patients now and present with pretty similar symptomatic burdens. But of note is that the patients that were cured after age 18 or who were never cured overall demonstrate a higher incidence of intraprocedural and post-procedural hemorrhagic complications. So waiting to pursue cure may actually lead to riskier procedures, which can drive worse outcomes. And these patients also presented with significant residual symptoms and focal deficits that persisted on very long-term follow-up. So not pursuing cure may have long-term clinical consequences. Really, outcomes for patients have improved significantly over the last 2 decades in vein of Galen malformations as we've kind of improved and honed these techniques and technologies. We really see that this range of clinical presentations amenable to embolization has significantly widened from what we used to consider appropriate in the last 15 years. This cohort of patients that has complicated pathology and anatomy can be safely and effectively embolized using new miniature balloon microcatheters. And we're able to now utilize transvenous approaches as a safe and effective option to curatively embolize these patients, knowing that going for a complete obliteration leads to long-term clinical outcomes in these patients as well. And so really, in terms of next steps, Like I mentioned, there is those two identifying risk factors and diagnosis and triage. So this past year, I have been working on a multi-omic analysis of vein-of-Guillain malformations. It's a prospective clinical trial looking at integrating genomic and transcriptomic data to identify expressions within whole blood to understand what molecular targets are being upregulated. We're also using a proteomic analysis to identify low-cost targets for identifiability in screening in other hospitals. This data is actually coming back within the next week or so, and so hopefully the next time I talk, I'll be able to have some updates on this information itself. We're also working with pediatric cardiology to identify markers on MRI and echocardiogram that could predict the need for a neonatal intervention prior to the baby being born, so we can create a new risk stratification score to triage and manage these patients. And really, I just want to give a strong shout out to my mentors, Dr. Joanna Fifi, Alejandro Berenstein, Tomo Shigematsu, and Raj Srivastava this past year. Your mentorship this past few years has been nothing short of invaluable and so incredibly appreciated. I don't think I would have been in anywhere the place I am now without all of you. I also want to thank all the people that I've worked with this past year in a number of projects. Dr. Bettison, Dr. Mako, Dr. Kellner, Dr. Morgenstern, Dr. Gattan, Dr. Schreiber, Dr. Majidi, Dr. Caton, the neurocritical care team, Dr. Delman, Dr. Balchandani, Dr. Chapeau, and the rest of the department for helping fund this, along with multiple residents, fellows, the Cerebrovascular Center, Jess, Michelle, Ryan, and then the other medical students who really none of this would have been possible without. And I really just want to highlight, as I'm going into my sub-I, this past year with the department has been so incredibly productive, more than I ever could have hoped for. I've been able to submit my manuscripts, give multiple talks, and I'm really just looking forward to working with the department this coming year as I work on my sub-I this next month in July. Thank you.
Nice job, Alex. Alex is really, as all the students today have, but has really set an example for sort of putting your head down and getting a lot done in a year. I want to give Raj a chance to ask a question.
Yeah, Alex, fantastic.
I use up all the time.
Yeah, sorry, it'll be quick.
No, go ahead.
So fantastic talk, Alex, and it's always been fascinating for me. I don't know if it's a straightforward question, but vein-of-Guillain malformations in terms of the angiogenesis profile is so uniquely different than AVMs. Based on your studies and what you guys have seen, maybe this is more of a multi-omics type question, but do you think that difference in its angiogenic profile is really what is one of the many reasons that makes this so challenging in terms of, obviously there's venous outflow, there's different pressure gradients, but are you guys seeing changes during treatment for angiogenic profiles?
Yeah, absolutely. I think we can really subset a lot of our patients. We call it like massive angiogenesis, for example. But this angiogenesis really significantly complicates the management. We often find that we embolize from multiple pedicles and have a pretty significant reduction in flow through the malformation, only to come back 6 months, 9 months later and see that there is a further degree of angiogenesis that we now have to also tackle as well. It really just makes management very challenging, as in addition to the formation of new vessels, these vessels are often extremely small. And so we're also losing accessible pedicles that we can use for a really safe and approachable way to treat these malformations itself. And if these patients require more treatments, of course, you obviously have complications of putting the patient under radiation for longer periods of time, embolizing as they grow older. We also know that this angiogenesis progresses with age as well. We see that over time, this can present either at the beginning or just during their care itself. And so really, what seems to be a more straightforward AVM ends up being extremely complex because of this expression profile. There have been a lot of hypotheses that have been developed about it relating to local hypoxia, to wall stress, but really no one has been able to put a really strong finger on what factors may be at play. And so we're hoping with this data we'll get in the next week or two to have a really good picture of what is driving this angiogenesis to this degree in only some patients.
I'll give Joanna a chance to make a comment before we move on.
Yeah, I'd like to say it's been a real pleasure having Alex with us this year. He's really, as Peter said, put his nose down and gotten a lot done. And there's still, even though it's been a few decades that Dr. Berenstein started treating these patients and we've made such advances in treatment, there's still a lot to learn. There's still a lot that we don't know. And I think of the vein-of-Guillain, as Raj was maybe alluding to, as a window into brain AVMs, because now you have kind of a uniform population that you could study and look at things like angiogenesis and the different, hopefully we'll find some upregulated proteins and molecules in these patients as they develop angiogenesis, and then can start thinking of targeted therapies. I think the whole field, we're at the beginning of a field of vascular malformations where we're going to have medical therapies at some point a few decades from now, similar to cancer, targeting specific molecules. So I think it's a good population to start with. So congratulations, Alex.
Thank you.
All right, thank you so much. We'll move on next to Muhammad Ali, who graduated first from Cornell with his undergraduate degree in neurobiology and behavior before coming to Sinai, and did a Master's of Science in Clinical Research over the last year while working in Dr. Kellner's lab. He is going to be talking to us about some of the ICH work that he did this year as a follow-up to his research day presentation last week. And just a reminder to everyone, we're going to try to keep these to 15 minutes or less so that we have some time for questions for everybody.
Thank you for that introduction, Dr. Morgenstern. My name is Mohammed, and today I'll be presenting one of my scholarly year projects, longitudinal characterization of residual cavity after surgical evacuation of intracerebral hemorrhage. My scholarly year mentor was Dr. Kellner. A little bit on the funding and disclosures for this project. My scholarly year was funded by the NIH TL1 pre-doctoral fellow training grant. And my master's degree this year was funded by the Mount Sinai Dual Degree Portal Program, which also provided significant statistical oversight to this project. The project itself was not funded, and these are Dr. Kellner's disclosures. So intracerebral hemorrhage is a devastating form of stroke that renders 75% of survivors functionally dependent. Unfortunately, there's currently no definitive treatment for the condition, with past surgical trials having failed at demonstrating superiority in the primary outcome. Though results of the ENRICH trial presented recently at AANS are challenging that conclusion. So after effective evacuation of the hematoma, a remnant cavity, which the hematoma had once occupied, is left behind. On the right of the screen, you'll see a right basal ganglion stroke, and then postoperative imaging demonstrating the remnant cavity, as well as some remnant hematoma marked in blue and red respectively. And then at 12 months of the same patient, you see the residual cavity retained. So in cohorts of non-surgical patients, a greater residual hematoma volume has been associated with poor functional outcomes. So for example, Davalos et al. Dichotomized patients by their long-term functional outcomes and found those with good outcomes had a residual hematoma hypodensity of just 8 milliliters at 3 months. Whereas those with poor outcomes had a residual hematoma hypodensity of 36 milliliters. Both cohorts had comparable initial hematoma volumes of around 50 milliliters. Though ICH lesions have been longitudinally characterized in patients receiving medical management, they have not been characterized after surgical evacuation of the hematoma. So in this project, we hope to characterize, investigate the remnant hematoma cavity in patients who underwent minimally invasive ICH evacuation. To this end, we defined and characterized a new term, the relative cavity volume, which was calculated as the ratio of the remnant cavity volume at any given point to the preoperative hemorrhage volume. The goals of this project were really threefold. The first goal was to determine which presenting operative characteristics were associated with the relative cavity volume on both the postoperative and final follow-up CT scan. Next goal was to explore whether RCV on final CT scans was associated with long-term functional outcome. And the final goal was to develop a time course for relative cavity volume up to 2 years after evacuation. In doing all this, we kind of hope to characterize that post-evacuation cavity and provide preliminary evidence for any potential clinical relevance. We hypothesized that the lower RCV on longitudinal scans would be independently associated with both good functional outcomes as well as measures of operative success. So from December 2015 to December 2021, patients presenting to our healthcare system with spontaneous supratentorial ICH were triaged to a central hospital for potential surgical evacuation. Inclusion criteria included age greater than or equal to 18, a preoperative hematoma volume greater than or equal to 15 milliliters, a presenting NIHSS of greater than or equal to 6 and a premorbid MRS of less than or equal to 3. For this specific project, patient who underwent evacuation and had at least one CT scan available at least 3 months after evacuation were included in the analysis. So the general imaging protocol is outlined here. On admission, patients are administered in CT and CT angiography of the head and neck. Then there's a postoperative CT that's administered approximately 24 hours after the procedure. And finally, additional longitudinal imaging is required on a case-by-case basis for routine follow-up, neurologic worsening, or EVD removal. So for image analysis, preoperative and postoperative hematoma volume and cavity volume measurements were performed using the semi-automatic volumetric segmentation software 3D Slicer. For the measurements, we chose a seed point and set lower and upper bounds of 40-80 Hounsfield units and negative 130 Hounsfield units for the hematoma cavity and the cavity volume respectively. The outlines were then generated from this, were adjusted to fit into the area that's corresponding to the hematoma cavity. The cleared cavity volume was also measured on longitudinal CT scans with the same upper and lower bounds as employed on the postoperative scans. There was no evidence of residual hematoma on longitudinal scans in any patient, so hematoma volume wasn't longitudinally tracked like cavity volume was. Hematoma volume and cavity volume measurements were performed together with the senior author, Dr. Kellner, for the first 10 patients, and then independently by 3 authors, me, Dr. Ascanio, and Colton. And we corroborated our results after we independently assessed the volumes or measured the volumes, and we were blinded to the outcomes as well as the presenting and operative characteristics of the patients. So 108 of 226 patients who underwent evacuation from 2015 to 2021 had longitudinal CT scans. 58% of the patients were male, 34% were African-American, 70% had chronic hypertension, and 42% were some sort of chronic antithrombotic therapy. The presenting neurological debility was moderate to severe as evidenced by a median NIHSS of 15. The median ICH score was 2. The median preoperative volume was 39 milliliters. 31% of patients had an IVH with a median MGS of 9, and 55% of patients had a deep hemorrhage. 78% of patients were evacuated endoscopically, with the remainder being evacuated surgiscopically. The median postoperative hematoma volume was 3.5 milliliters for median evacuation percentage of 90%. 83% of patients achieved a residual hematoma volume less than or equal to 15 milliliters. This is a standard set by post-hoc analysis of the MIST-T3 trial. The median time to evacuation was 21 hours. 2 patients experienced symptomatic postoperative bleeding, and 51% of patients achieved a good long-term functional outcome. Those with longitudinal CT scans were more likely to be insured than those without longitudinal CT scans and more likely to have good 6-month functional outcomes. This is largely because patients who are more functionally debilitated are less likely to appear to follow-up appointments. There were no other substantive differences in the demographic, clinical, radiographic, or outcome variables between the 2 cohorts. So 484 total CT scans were obtained, 108 were preoperative scans, and 108 were postoperative scans. After evacuation, a median of 24 hours after surgery, the median cavity volume was about 2.4 milliliters for a relative cavity volume of 5.8% or 0.058. Given that the median residual hematoma volume reported in the last slide was 3.5 milliliters or 8.9% of the preoperative lesion, the median postoperative cavity and hematoma comprise a total of just 15% of the original lesion. This all indicates that there's a significant reduction of the lesion 24 hours after evacuation. Factors associated with a higher relative cavity volume on multivariable and propensity score match analyses included a delay in time to evacuation and higher evacuation percentage. There were 268 longitudinal scans. The median time to CT scan for all longitudinal CT scans for the patients was 11 months, and the median time to CT scan for each patient's last CT scan was 13 months. There was an average of 2.5 follow-up CT scans per patient, and on the final CT scan, which happened to be a median of 13 months after evacuation, the median cavity volume was 9.4 milliliters, and the median relative cavity volume was 0.25. which was significantly greater than the paired postoperative RCV as evidenced by the paired t-test p-value less than 0.0001. So multivariable and propensity score match analysis of factors associated with higher RCV on final CT demonstrated a significant association with a delay in time to evacuation, but this time a lower evacuation percentage and achieving a residual hematoma volume greater than or equal to 15 milliliters. Interestingly, as can be seen in the upper right-hand panel, a greater percentage of cod debulk was associated with a greater RCV on the postoperative CT scan. This makes sense as removing more blood initially produces a larger postoperative cavity. However, long-term, as can be seen in this inverse relationship in the lower right panel, removing more blood products actually decreases the remnant cavity burden longitudinally. So we have a flipping of the association of evacuation percentage with RCV from the postoperative scan to the final CT scan. Next, we assess for associations of RCV with patient outcomes. Both multivariable and propensity score match analyses demonstrated a greater RCV on the final CT scan was associated with worse long-term functional outcomes with a beta prime RS of 17.6 and a p less than 0.0001. So to put this into perspective, 90% of patients with an RCV on the lower end from 0 to 0.25 had good functional outcomes. 54% of patients with an RCV from 0.25 to 0.5 had a good functional outcome, but just 5% of patients with an RCV greater than 0.5 had a good functional outcome. On the bottom here, we'll see two patients. On the left of your screen, you'll see a patient with a left basal ganglia stroke, but with an RCV of just 0.19. This patient had an MRS of 2 at 6 months. This patient on the right of your screen, also with a left basal ganglia stroke, had an RCV of 0.57 and had a 6-month functional outcome of MRS of 4. On the left is a cubic spline regression model demonstrating a significant relationship between RCV on the final CT scan and the probability of a good outcome, with an RCV greater than 0.5 being a strong indicator of functional debility. On the right is a receiver operating characteristic curve with an AUC of 0.91, demonstrating outstanding discrimination for RCV's prognostic value for a long-term functional outcome. Finally, we ran a time course analysis where we binned each patient's follow-up CT scan into 4 distinct time slots, the 3-month, 6-month, 12-month, and 24 months. Wilcoxon scores for RCV increased stepwise from 0 to 3 months post-evacuation, then 3 to 6 months post-evacuation, but decreased thereafter to 12 months post-evacuation and stabilized thereafter to 2 years after evacuation. In summary, we longitudinally tracked the remnant cavity volume after minimally invasive evacuation of spontaneous ICH. To that end, we defined and characterized a new term, RCV, which was calculated as the ratio of the remnant cavity to the preoperative hematoma volume. RCV in our cohort of 108 patients was longitudinally dynamic, steadily increasing in size up to 6 months after evacuation, decreasing thereafter to 12 months after evacuation, and stabilizing to 2 years after evacuation. We found that a lower RCV on final head CT scan was independently associated with both a better long-term functional outcome as well as measures of operative success, including early time to evacuation, higher evacuation percentage, and postoperative residual hematoma volume less than or equal to 15 milliliters. This indicates that our findings, taken together, our findings suggest evacuating ICH early and effectively may mitigate some of its long-term sequelae. We also present preliminary evidence for the utility of RCV as a longitudinal marker of clinical outcome. And then finally, further research is needed to elucidate the mechanisms linking RCV to functional outcome. For instance, we hypothesize that a greater degree of brain atrophy could cause a larger cavity size in the same way brain atrophy could cause hydrocephalus ex vaccio. Thank you for your time. And before I ask for questions, I just want to acknowledge Dr. Kellner and all my co-authors on this project. Thank you.
I'll just start by saying, great job, Mohammed. I saw you really mature throughout this project as you were doing your stats degree and you're getting your master's, and you really took this data set and did every possible analysis to get the information that we were looking for out of the data, and did some really rigorous stats on it. And I thought you really did a great job.
Thank you.
Mohammed, what you mentioned that you think further research is needed to sort of bring this into the mainstream and make it one of the tools in everyone's armamentarium for treating ICH. How do you envision the next steps from here?
In terms of understanding the biological mechanisms of what's driving the association, or more like?
No, I mean, as a follow-up to the study you presented here, like how would you more cement the evidence that you're generating?
Yeah, well, definitely. So first and foremost, this is a retrospective study. So the data set we have is limited because there's biases in terms of which patients present to their follow-up appointments, right? So some patients are more likely to present and others are not. And in fact, I have some data here, extra tables. So like most patients present to 3 months, but not everyone presents to 6 months, 12 months, or 24 months. So I think the best way to remove some of that bias is to do a prospective study where we like enroll patients. But I feel like just for the purpose of determining the clinical value of RCV, that's not necessary. So we can like do like combine it with an ongoing RCT where we further assess where we assess RCV as like a secondary goal of the project. So I think that's the next step, is take this from like a retrospective to a prospective study, and then to see if it's applicable at other centers and not just our center, and not just our specific way of minimally evacuating ICH, but other ways of minimally evacuating ICH.
Well, great work, Mohammed. We'll move on to our last presenter for this morning. So Christina Rossitto finished her undergraduate degree at MIT in biological engineering before coming to Mount Sinai. She is also a rising fourth year student. She'll be doing her sub-I this summer. And she spent the last year working with Dr. Kellner looking into a novel way of imaging the brain after ICH using sonalucent cranial implants and transcranial ultrasound. So looking forward to hearing what you have to present this morning.
Thank you. Okay, can you see my screen okay? Okay. Great. So yes, today I'm going to share our experience with transcranial ultrasound through sonalucent cranioplasty after minimally invasive ICH evacuation. This research was the primary focus of my scholarly year with Dr. Kellner. Here are our disclosures. So as we all know, ICH is a devastating disease with significant one-year mortality. A meta-analysis of the randomized clinical trials on minimally invasive surgery for ICH demonstrated promising results regarding functional outcomes. And recently, as Mohammed said, at AANS, the ENRICH trial was presented, which was a multi-center RCT comparing hematoma evacuation to medical management. And ENRICH demonstrated that patients with lobar hemorrhages between 30 and 80 milliliters benefited from minimally invasive surgical evacuation. So patients who undergo ICH evacuation require frequent imaging to monitor for hemorrhage resolution, surgical rebleeding, and hydrocephalus. This is typically done with CT. However, CT has significant downsides, including transport burden, radiation exposure, and costs. In fact, one outside study showed that complications can occur in up to 1/3 of intra-hospital transports. This is because critically ill patients are frequently unstable and unable to tolerate transport necessary to monitor an ongoing or evolving condition. Recent research has shown that sonalucent cranioplasty implants are safe in other pathologies. Materials that allow ultrasound waves to penetrate them include PMMA, which is the focus of this research, and also PEEK and polyolefin. These sonalucent implants are of interest because ultrasound is less expensive, it doesn't give off radiation, and it can be performed at the bedside. Therefore, point-of-care ultrasound might be an innovative solution to serially monitor neurosurgery patients. We've used these PMMA cranioplasties in patients who have undergone hemicraniectomy, and they've offered great visualization of the neuroanatomy. Here's another patient who underwent cranioplasty after hemicraniectomy, and at the follow-up visit, we could monitor the size of his ventricles in the office. So given that a 2-centimeter craniotomy is created in ICH evacuation, we hypothesized that this could be a potential window for ultrasound. So here we'll review consecutive patients who underwent ICH evacuation with subsequent sonalucent cranioplasty and compare them to controls. Here's a patient who underwent evacuation and EVD placement, which goes through the notch in the cranioplasty. Here's another image of a patient who underwent a laterally approached evacuation, and they did not require an EVD, so there's no notch in that implant. So ultrasound was completed in the ICU, on the floor, and in the clinic. And within the first week, it was performed sterilely. And then afterwards, it was performed with ultrasound gel or bacitracin as the coupling medium. And I just want to thank Dr. Reynolds here because she has been integral in troubleshooting the ultrasound process, from reviewing sterile techniques to analyzing the images in the following slides. Here is how the imaging process looks during a clinic appointment. So to validate the safety of this, we compared the first 20 consecutive patients who received the sonolucent cranioplasty to the 60 consecutive ICH evacuation patients who did not receive the sonolucent implant. We found no significant differences in the patients presenting age, gender, or ethnicity. We also found no significant difference in the patient's clinical severity, such as the NIH stroke score, the hemorrhage location, or presenting volume. And there was no significant difference in ICH evacuation percentage. For in-hospital outcomes, there was no statistical difference in procedural duration, EVD placements, or length of stay. Importantly, there have been 0 cases of ventriculitis, wound infection, or wound revision in the cohort. For patients who were seen at 3 months, there was no significant difference in functional outcomes. So here are some of the images that we've acquired through these patients. Here you can see the CT is in the top row and the ultrasound is in the bottom row. There's poor visualization initially. These images were acquired within the first week. You can make out the ventricles here. And then later at the 2-month visit, the image is very clear and you can appreciate the ventricular caliber. Here is another patient in whom we can visualize their ventricles at the 1-month post-op visit. At this patient's 6-month visit, we could get a clear look at both posterior horns of the lateral ventricles through the implant because they had a parietal approach. Lastly, here is the patient who I showed earlier with the lateral approach evacuation. And within the first couple of days post-operatively, we could visualize the midbrain within the first week. So here's the comparison. There have been challenges during this process. Firstly, this is a new type of cranioplasty, so there's a learning curve to placing it in the OR. There's added time to the procedure to mortise the phalanges to make the implant flush with the skull, and you can't use Surgiflo, gel foam, or staples at the end of the procedure because that can obstruct the ultrasound. Additionally, point-of-care ultrasound is not in the neurosurgery workflow, with the exception of pediatric neurosurgery and bypass patients. So it's been a learning process for our team. The biggest limitation has been the image quality. Since the surgical approach for ICH evacuation is determined by the longest axis through the hematoma, there's not standardization in the images like an axial or sagittal CT. Additionally, although the goal was to monitor for rebleeding immediately post-operatively, there's often surgical products that obstruct the view. This is because continuous fluid is needed as a coupling medium for ultrasound waves to penetrate, so air or Surgifoam can deteriorate the image. Lastly, there's a narrow field of view through the implant, so imaging is not as comprehensive as head CT or MRI. But we've found solutions to some of these challenges. The company is iterating on the implant shape based on surgeon feedback, and Dr. Kellner and Dr. Reynolds have been incredibly helpful leading the imaging sessions and integrating it into their workflow. Dr. Kellner and I recently presented our findings at a neurosonography summit, and we were able to talk over some of these challenges. The device is being used at Hopkins for hydrocephalus and at NYU and Lenox Hill for bypass, so it was helpful to speak with those colleagues about their experience. Dr. Kellner and I are leading a clinical trial for this device, which is prospectively enrolling patients. It's called TUSC MIS. Our goal is to validate some of the measurements on ultrasound compared to CT and the socioeconomics of this approach. We have a parallel trial called TUSC EVD, which is looking at the device in patients who received EVDs without evacuation. These trials are ongoing. So in conclusion, we found that transcranial ultrasound through sonolucent cranioplasty after minimally invasive ICH evacuation is safe and feasible. However, imaging quality varies with ultrasound operator and time frame. I want to use the last couple of minutes to briefly touch on some of the other projects I worked on this year. I studied engineering before med school, so I'm particularly interested in innovation on medical devices and imaging in the OR. And something that's so unique to Sinai Neurosurgery is the ability to collaborate with engineers in Sinai Biodesign and industry groups to improve neurosurgical technologies. Last week, I shared my experience using surgical theater to test virtual reality for surgical education. I've also worked with Dr. Betterson and Hawley to review the value of heads-up display intraoperatively, and with Dr. Kellner and Dr. Mako to review advanced imaging techniques in ICH. I've also joked that this year is like getting a master's because I learned so much about clinical trial design by writing the ultrasound trial protocols. I've learned from the research office on clinical trial management as the clinical research coordinator for these ultrasound trials, as well as MIND, which is an ICH evacuation trial. And I've performed patient consenting for other ICH evacuation and EVD trials. And lastly, I got a crash course on grant writing this month when Dr. Kellner, Turner Baker, and I applied for the NSF I-Core grant with the Chill Cooling Catheter Project. And we were recently awarded $50,000 in federal funding to participate in an accelerator program, translating technology from the lab to commercial ventures. I'm so grateful to Dr. Kellner and all of my mentors in the neurosurgery department and Sinai Biodesign. I also want to thank the residents who were really helpful this year, checking in on projects, and the research office for teaching me what goes on behind the scenes in a clinical trial. Thank you so much for this opportunity.
Thanks a lot. I'll start off again by saying great job. I mean, you got so much done this year. What you were just showing was really the clinical trial continuum, from device inception to designing a clinical trial around evaluating a device, interacting with the company, and getting the trial done. And you really worked through a lot of challenges. This was not easy to make work at the bedside. Maybe Alex can comment, but you know, trying to do ultrasound through that small hole, it's not really ready for prime time and needs a little bit of finagling every single time. So thanks for your dedication on that.
Christina,
yeah, I just want to say, Christina,
go ahead.
Sorry, Peter, but Christina, the amount of work you put into this is really incredible, and it's been a challenge, and you haven't really let that get to you, which I think is the most important thing, sort of in trying to work on something that's so brand new. So well done, and we really appreciate, as the Neuro ICU, getting to be involved in this.
Thank you.
Well, so as an ultrasound devotee, I'm very interested in this, but you know, do you imagine that there will be ways to maybe create sonolucent burr hole covers or entire sets of sort of cranial plating systems that are sonolucent in the future, where, you know, perhaps for other types of craniotomies where we don't want to take out a whole piece of the skull and leave it out and do a cranioplasty, we could make a large burr hole and then affix with sonolucent materials that would allow us to ultrasound through them. Do you think that could be possible in the future?
Definitely. I think that if what you're saying is small, different size burr hole covers that are sonolucent, it's already starting to be used at very few centers, like for bypass at some centers or hydrocephalus. And so I do think that it's moving towards the direction of being more popular for all different pathologies where craniotomies would be required.
We have a question in the chat from Dr. Delman. Does the use of bacitration, can you use bacitration instead of sonogel would that impact the visualization and quality of diagnosis?
So we haven't quantified, I can't say specifically how much it impacts the ultrasound wave penetration. We've found that it does work as, and the images are comparable, which is why we've felt comfortable using it just after the first week month to try to prevent infections even more. I would guess that it is slightly different than ultrasound gel, but because it's still allowing the waves to penetrate, we've been using it just to mitigate any infection risk.
Yeah, anecdotally, it works quite well. And in a pinch, in the ICU, we'll even use Purell instead of ultrasound gel when we don't have it, and that works quite well too. So, yeah, I think it's been working okay, and I think the risk of introducing infection on day one is quite high.
All right, well, thank you everyone again. Really, really fantastic work from all the students. You've shown how much you can accomplish in a year. Imagine if you had 3. And thank you again to all the mentors who dedicated their time and funding in their labs to supporting these excellent students. And I think that's all for today.